Good morning. Welcome to Dental XP. My name is Luca Gobbato. I work on this presentation with Dr. Gianluca Panitz. And what we are going to talk today is the key factor for aesthetic on implant restoration. I will cover the first part of this presentation, talking about the surgical aspect, as of course I'm a periodontist. We are going to talk about aesthetics because the last challenge of dentistry today is to mimic the nature of the natural dentition with the implant-supported restoration. Because when it comes to implants, it's not important only the size, the shape, the position and the color of our restoration, but is extremely important and probably more important, the peri-implant soft tissue compatibility with the surrounding gingiva and mucosa. Because this must be as similar as possible to the tissue that is surrounding the natural dentition next to our implant prosthetic support restoration. So there is a nice article that was published by Dr. Panitz at University of Padua that explained the concept very well, because no matter which material we are using underneath the tissue of our implant-supported restoration, we always are going to have a discoloration induced by the gold, the titanium, or the zirconia material. So what really matters is the thickness of our mucosa. Mucosa thickness is in fact a crucial factor in terms of discoloration caused by different restorative material, as we have seen in that publication. So that's why we need to focus on the term peri-implant biotype. But before going to talk about peri-implant biotype, we need to focus on periodontal biotype, because before extracting the teeth, of course, the patient were related to a specific type of biotype. So thickness is extremely important, as Siebert and Lindy, they first described the term periodontal biotype, identifying the architecture, dividing the architecture in two types of scallop architecture and flat architecture, and as well the thickness of the tissue. As Joseph Kahn showed us in a recent publication, we saw that we can identify this type of biotype just inserting a probe underneath the tissue. If we have a thin soft tissue and we can definitely see the shadow of the probe underneath the tissue. Instead, if we don't see the shadow of the probe, then we are going to face a thick periodontal biotype. We try to analyze this as well from the shape of the teeth, and we analyze several dental students in order to come out with a classification of tooth shape. We related the length of the crown to the length of the contact surface, and then we saw that if the ratio between the length of the crown and the length of the contact surface is less than 43%, we are going to face a triangular tooth shape. While if this length is is higher than 57%, then we are dealing with the square tooth shape. And then we identify these three types of clusters based on tooth shape, and we analyzed some periodontal parameters, such as the keratinized mucosa and the height of the interproximal papilla. And we saw a statistically significant difference in these two measurements of quantity of keratinized mucosa and height of the interproximal papilla, which is definitely longer in patients with the triangular tooth shape compared to patients with the square tooth shape. And this we will see, it will be extremely important when it comes to implant dentistry, in particular when we are going to replace a single central incisor that is going to be missed, if that is missing, or it's going to be extracted. So we can definitely change the periodontal biotype around natural dentition, just grafting the area with the connective tissue graft, for example, increasing the thickness of the buccal aspect of those teeth. When it comes to implant, the periodontal biotype, and therefore the peri-implant biotype, plays a very important role for achieving our aesthetic results. So when we are focused on the periodontal biotype, talking about implant, the clinical implications for the implant treatment are extremely important and related to periodontal biotype. Let's say, for example, we can face two different situations when we are dealing with, when we are extracting the teeth. We can have one situation with the intact facial plate, and we can have the opposite situation with the absence of the facial plate. So let's see, first of all, when we have a situation in absence of facial plate. In my hands, and what I normally do in my clinic, if I have an absence of the facial plate, I normally graft the area. So I don't go for an immediate implant placement in this situation, but I normally use a socket preservation technique with a cross-link collagen membrane, so a slow resorption rate membrane, and I preserve the area using FDBA, sometimes mixed with the xenograft material. So looking at this case, for example, I have a fracture bicuspid with the two premolar are fractured with the periodontally and endodontically involved lesion. So the last treatment is, of course, to extract these teeth. But if I let this area healing by itself, I will probably not have enough bone to place in a correct position my implants. So what I'm going to do is to graft the area at the time of the extraction and cover the bone material, so the FDBA, with a cross-link collagen membrane. And then I'm using some interproximal suture to approximate the flap, but before I'm doing internal horizontal mattress to take away the tension from my edge from the edge of my flap. And after 6 months, you can see the amount of bone we gain, and this is bleeding bone, so it's absolutely fine for me to go ahead and place my implants without any problem in a correct position. And you can see from the radiograph the stability of this type of regeneration after 3 years that the implants have been loading. The literature is absolutely clear when it talks to socket preservation. The systematic review published in a Clinical Oral Implant Research 2012 by the group of Mariano Sanz and Complutense in Madrid is telling us that the socket preservation is a technique that works, and it works better when we are using a membrane and when we are elevating a flap. That's why, looking for example at this case, this guy had both of the two central incisor fracture. You can see easily the fractures from the CBCT that I took in my clinic. And when it came, I of course prepare a Maryland bridge in order not to leave the patient without the two central incisor. But I elevated a big flap and I went ahead with the piezo surgery and removed those root tips that were fractured. So I removed the root tip in trying to be as traumatic as possible in order not to break that facial plate. After I removed the root tip, I did a thorough cleaning of the soft tissue, the granulation tissue that was inside the alveolus. And at that point, I mixed some FDBA with the xenograft. The reason I'm doing this is because the xenograft is going to give me more scaffold for the area I want to graft outside the socket. In fact, as you can see now, I'm doing a releasing type of incision in order to advance a little bit my flap. And I did not graft only inside the socket. As I said, I'm going to graft as well outside the socket. And then, of course, I'm going to cover everything with a cross-link collagen membrane, which will be extended much more than just the area I would like to graft. And at this point, I'm ready to suture the area with the internal horizontal mattress, which will take away the tension from the edge of my flap. And then with the single interrupted suture, I'm going to approximate the most coronal part of my flap. So after 6 months, you can see we are ready to place automatically the implants. We can do this flapless. We use the help of the Implant, the software which let us plan the implants in the software, and then once we have done this, we check, of course, for the emergence profile of our implant that has to come palate palatally from the restoration, so we can give the patient a screw retain type of restoration. I'm sure Gianluca is going to talk about this. And after we have the surgical guide delivered, we are definitely ready to do the surgery, which will be very easy and very short. It will take approximately about 10 to 15 minutes. And the good thing about this is that we already have the abutments that is going to be placed at the time of the implant placement, and is never going to be removed from the patient's mouth. The opposite situation is when instead we have an intact facial plate. When we have an intact facial plate, the situation is completely different for me, because now I'm not going to graft anymore and to do a delayed immediate placement, but I'm going to do an immediate implant placement, which means that the key factors for immediate implant placement are a correct three-dimensional position, a placement of a slow resorption material in the gap between the implant and the buccal bone plate, and then I'm going to do a soft tissue augmentation, which I believe is the real key for the success in the aesthetic area. So looking at this case, this guy, for example, was sent to my clinic because he had a fractured central incisor due to a basketball accident during a basketball game. So the first thing, of course, I exposed the CBCT and I identified the fracture. So the tooth was, of course, not treatable. And I prepared at that time a Maryland bridge, and I went ahead, extract the tooth, and check, of course, for the integrity of the buccal plate. After that, I went ahead and placed the implant in the three-dimensional correct position. I grafted the area with the xenograft. So in this case, I'm using only slow rate resorption material, such as xenograft, which I want to be there because it's going to support the thickness that I need to have in order to achieve a good aesthetic result. But the key point is to use the soft tissue augmentation. Soft tissue augmentation like this is not going to seal just the socket, as you can see in the picture, but is going to be extended on the facial aspect of my missing central incisor. So I'm going to increase the area on the buccal aspect of that socket. You can see after 2 weeks the healing. The Maryland bridge was kept out of the occlusion, of course, and you can see a radiograph that is just checking for the integrity of our implants. After 5 months, we are ready to do a second stage surgery. We deliver a provisional restoration, and this is the type of healing I would like to see after 3 or 4 months of tissue conditioning with the provisional. So looking from the buccal aspect, on the occlusal aspect, you can easily see that we maintain almost inalterate the thickness from the palatal to the buccal aspect of that ridge. And we can go ahead at this point and deliver the final crown. And we have a 2 years follow-up now with the patient smiling and extremely happy with his implant-supported restoration. So this was a pretty much straightforward case. I would say easy, even because the tooth shape is square. You see the interproximal papilla is not as long, and the contact surface is definitely longer than in a tooth shape, than in triangular tooth shape. So interestingly, we ran a meta-analysis which we will be published soon in JOMI in 2013, in which we try to associate the periodontal peri-implant parameters such as bleeding index, gingival index, plaque index with the amount of keratinized mucosa. And we identified 2 groups, implants with more than 2 millimeter and less than 2 millimeter of keratinized mucosa. But interestingly, we did not found any difference in supporting that we need the keratinized tissue around the implants to maintain health and tissue stability. So in conclusion, the evidence was scarce and no conclusion could be drawn. But we know that if you want to achieve a good aesthetic result, keratinized tissue is extremely important. And if we look at if we go back to the periodontal biotype concept, we know that if we have thin, hard, and soft tissue, the risk of the recession is definitely higher. So the same concept can be applied to dental implants, but there is a main difference between implants and teeth. Is that when we are going to place the implant, we can decide where to place the implant. So we can increase the thickness of our tissue, just placing the implant a little bit more palatal and maybe a little bit more apical. So looking at this girl, for example, the implant position was absolutely wrong. She had an implant on the canine that was placed too buccal and too deep. So in order to restore and to increase the aesthetic of this girl, the only treatment I could do was to remove the implant, to rebuild the hard tissue, to rebuild the soft tissue, and then to place the implant in the correct three-dimensional position. So it's much easier to start with the correct implant position. As we can see from this case, this is another girl with a fractured central incisor. I went ahead and after exposing, of course, the CBCT to identify the fracture and the amount of the integrity of the buccal plate, I removed the fragment of the root tip. I used the piezo surgery in order to create the osteotomy. And then I completed the drilling sequence for placing my implant in the correct three-dimensional position. I grafted the area in between the implant and the facial plate with xenograft, so slow resorption rate material. And as I was saying before, the key of the success is to go ahead and take that tissue, that connective tissue from the palate or from the tuberosity, we will see later. And after I took the tissue, this tissue is not going to just seal the socket, but after I created a pouch on the buccal aspect of that socket, I'm going to increment the buccal aspect of that socket. So I'm securing the graft with the chromic gut suture, and then at the delivery of the Maryland bridge, I'm going to put some pressure in order to keep in place that connective tissue graft. So the ovate pontic over the Maryland bridge is going to be inserted inside the socket in order to put some pressure into the connective tissue I just placed to seal the socket. So as you can see now from the video, the Maryland is delivered. And this is the picture I take at the implant placement, and at the time of the connective tissue graft was secured in place. And this is only 1 month post-op with the Maryland bridge in place. And after 4 months, we went ahead, prepped the other tooth, and delivered the crown on the number 9. And this is the final restoration with an implant, a patient which is extremely happy with the hair implant supported restoration. So as I was saying before, this type of connective tissue we can harvest from the palate or from the maxillary tuberosity. From the palate, I normally go ahead and take some the tissue from the molar mesial to the mesial line angle of the molar to the canine. And I don't see any type of problem, of morbidity problem normally. But patients are really not complaining at all when I go ahead and take the tissue from the tuberosity. The problem is that such amount of tissue is not always present in all of our patients. But if I can, I normally go to the tuberosity first, and if I need more tissue, then I go to the palate. So the key of the success, I was saying before, is definitely the biotype, it's definitely the thickness of the tissue, so the biotype around dental implants. So what we would like to see from the occlusal aspect of our implants is always this type of thickness, as you can see on the left side of the screen compared to what you see on the right side on the screen, that we have an extremely thin peri-implant type of tissue. So this is an example of what I'm saying, because this guy came to me because he was unhappy with his implant-supported restoration. He had the implant placed 4 or 5 years before, and then he moved to my hometown in Padova, and he came to me because he was extremely unhappy with the aesthetic result he had with this implant-supported restoration. So of course I exposed some radiographs, I checked for the integrity of the implant, and after I realized the implant was absolutely fine, I removed the crown, and I saw immediately what was the problem. So we didn't have enough thickness on the facial aspect of that tooth, of that implant. So the only good treatment for me here was to increment the area with the connective tissue graft, and I created a pouch on the buccal aspect of the implant, and I inserted a connective tissue that was taken from the tuberosity as well. And after several months of healing, I went ahead and of course we changed the composite on number 8, and we deliver a new ceramic crown on number 9. And you can see how now we gained a much better result in the architecture of our gingiva, and we gain definitely much more harmony in the smile of this patient. So our goal is always to reach adequate peri-implant tissue support. No matter where we are starting from, we always want to gain this type of thickness, and we can easily see this from the occlusal aspect of our implants. In particular, when the implant is in between natural dentition. Of course, the situation will be much more difficult when we are dealing with two natural teeth that have to be extracted due to a fracture, like in this case. So after I extracted the teeth and I check, of course, for the integrity of the buccal plate, the treatment is always the same. I go ahead, place the two implants in the two sockets, and then I grafted the area with the slow resorption material like xenograft. I of course check for the correct three-dimensional position of my implants, and then, as I showed you before, I'm going to do a connective tissue graft which will increase the volume on the buccal aspect of my extraction socket, but as well is going to seal that socket. The problem is, as you can imagine, is that after 5 months we are going to have higher resorption compared to just a single tooth. So in order to go from this situation to this situation, as I was telling you before, we can change the periodontal biotype around natural dentition. We can do the same thing around dental implants. So what I'm going to do is to take a huge quantity of connective tissue from the palate this time. I'm going to tunnel the area, and I'm going to insert the connective tissue and to secure the connective tissue with the suture. So I don't want to elevate a flap, I don't want to cut that papilla that it was very carefully preserved. So I'm just creating an envelope, so a pouch basically, around the two lateral incisors and around the two implants, and insert a connective tissue that was taken from the palate. And at this point, Dr. Panitz can start to basically shape the anatomy of the gingiva with the provisionals, and you can see after the insertion of the provisional, we were definitely able to achieve a good aesthetic result with the harmony in the architecture, in the scalloping of the architecture of the anterior sextant. Looking at the literature, it's very interesting to see that the complete filling of the interproximal space between two implants is present only in 10% of the cases. And this, to my opinion, to my experience, is due to the inter-implant distance that must be kept at least 4 or 5 millimeters, because sometimes I see that 3 millimeters are definitely not enough. Of course, the technology is going to help us, the research is going to help us. With Dr. Nevins at Harvard, we just published and we did this interesting article where basically we placed the implant 2 millimeters close to each other, but these are particular type of implants with particular abutment that receive some type of treatment with a laser, are called laser lock surface, in which the connective tissue are oriented, the fibers of the connective tissue are oriented toward the implant surface and not parallel to the long axis of the implant. So this is opening a new chapter in implant dentistry where basically we can hope to have a soft tissue adhesion or attachment to our abutments or to our dental implants. So concluding, the key factor for implant site development when we do not have an intact facial plate are basically to use a technique that preserves the socket with the cross-linked collagen membrane and some materials such as FDBA or xenograft. So this is my suggestion when we do not have an intact facial plate. On the contrary, when we have an intact facial plate, in my clinic, in my daily practice, intact facial plate is equal to immediate implant placement. So in that situation, I try to place my implant in the correct three-dimensional position. I place a slow resorption material in the gap between the implant and the buccal plate. And then, of course, I'm doing a soft tissue augmentation, as we saw is the key factor for achieving a good aesthetic result. So I thank you very much for being with me today. I want to thank you again, Dental XP, and please feel free to write me if you have any type of question to the email address you can see on the screen. Have a nice day. Bye.